Well, thanks very much, Raga, for that introduction. Despite my background, I'm actually going to be talking about what we've learned about the use of monoclonal antibodies for the treatment and prevention of COVID-19. Here are my disclosures. So this slide provides an overview, and by way of warning for those of you who are triggered by COVID and may suffer PTSD by my taking you back through what we all experienced from 2020 to the more recent era, I'll be talking about how technological advances made possible the rapid isolation and production of antiviral monoclonals, how these monoclonals were shown to be effective for treatment and prevention of COVID-19 and could be engineered, as we've already heard in earlier sessions, to have long half-lives, for example, by the LS modification in the FC domain of the antibody, but how the utility of these mAbs has been outpaced by viral evolution. And it's important to keep in mind in this context that SARS-CoV-2 evolution has not been driven by these monoclonals. This is not drug resistance in the classic sense, like we see with antimicrobial agents or even with antiviral small molecules. This is because the mAbs target the spike protein, which is the same thing that our own immune systems target. And as our immune systems adapted to the virus and began to become more effective against particular envelope sequences or spike sequences, the virus evolved to escape, and therefore the monoclonal antibodies that had been derived from previously infected or exposed people lost their activity as well, and I'll take you through all of that. So to start off, there have really been extraordinary technological advances over the last couple of decades that allow us now to very rapidly isolate and produce broadly neutralized, well, monoclonal antibodies. In this context, the slide was for broadly neutralizing antibodies for HIV, but originally this was done by taking memory B cells and then transforming them with Epstein-Barr virus to immortalize them, and then from the immortalized clones identifying those clones that recognize the antigen of interest and moving on from there. But the process became much more efficient by the development of lambda phage display libraries, where you could blindly clone immunoglobulin genes from B cells, express them in a phage display library, and then identify those phage that bound to the antigen of interest, and then engineer the antibodies from the genes carried in the phage, the human genes that had been introduced. And more recently, and more typically now, what's done is to take memory B cells to sort them by flow cytometry using the target protein of interest to identify and capture those cells, and then be able to directly clone those genes, amplify them, and put them into producer cell lines. This has become so efficient that it was faster to develop monoclonal antibodies against COVID-19 than it was to demonstrate that convalescent serum from infected people was effective in preventing or treating COVID-19. And so one of the first of these antibodies was bamlanivimab, and a rule in monoclonal world is make the name as complicated as you possibly can. But you'll recall that, and unpronounceable in almost any language, but you'll recall that the study of bamlanivimab plus etesevimab showed that there was a dramatic reduction in progression to hospitalization in symptomatic people, outpatients with COVID-19 who received these antibodies, and there was a 70% reduction in the risk of hospitalization. Also, Mike Cohen, in a study using just bamlanivimab alone, showed that this antibody in a nursing home setting was highly effective in preventing acquisition of COVID-19, symptomatic COVID-19. This was an amazing study done where when there were index cases in a residential long-term care facility, they would race with a mobile van with all the machinery needed to implement the trial and enroll as many participants, residents as they could, and they were able to demonstrate that at least among the resident staff, they had a dramatic reduction, not so much among the hospital, the nursing home staff itself, but among the residents, they were able to show reductions. Now, unfortunately, by the time this study was actually completed, the virus had moved on and bamlanivimab was no longer effective. And that's because SARS-2, as we saw, exhibited extraordinarily rapid diversification. And this was a real surprise to many of us because we knew that the RNA-dependent RNA polymerase of SARS-CoV-2, first of all, has a proofreading function and has a much lower error rate than other RNA polymerases, and certainly much lower than reverse transcriptase that those of us in the HIV field were used to. But the high fidelity of the polymerase was really compensated by the huge number of transmission events. So even if you have a very low mutation rate, if you're having hundreds of millions of transmissions, then you have ample opportunity for diversification to occur. And this variant selection occurred with each transmission event as well as within individual hosts. And we also know that persons with prolonged shedding, for example, people who are immune compromised and continued to produce virus for a time, may have served as a source for viral variation. So what we saw going into 2021, as we began the second year of the COVID-19 pandemic, was the gradual disappearance of the original parental strain, the transient emergence of the alpha strain, and then eventually replacement of those early strains with Delta. And that had profound impact on susceptibility to antibodies. So here you see emerging resistance to bamlanivimab, especially with this 484K mutation in the spike protein that, although bamlanivimab remained active against the alpha variant, it lost activity against beta, gamma, epsilon and iota never really made much of an appearance, but you can see the extraordinary fold change. But the combination of bamlanivimab and etesivimab remained effective, largely, at least against had some activity against alpha, but and lost substantial activity against gamma. Was still active against epsilon and iota. There was also the development of casirivimab and imdevimab by Regeneron, and here again showing the ability of the antibodies to significantly reduce the rate of hospitalization or emergency room visits by symptomatic people with symptomatic COVID-19 who receive these antibodies in the outpatient setting. And the, Cas and imdevimab had retained activity against this whole range of viruses to which the first generation antibodies became resistant, bamlanivimab and etesivimab. But this is all in a matter of months. And then sotrovimab was developed. This antibody actually had the LS modification and was intended to be able to have long-acting activity. And here, again, just briefly showing that in outpatients with symptomatic disease, there was a significant reduction in risk of hospitalization, about 80% reduction in the relative risk. But sotrovimab had good activity against all of the original variants as well as against Delta. But then came Omicron. So Delta was present from around the middle of the spring of 2021 all the way through till October, November of 2021. And then beginning in November of 21, and especially coming out in December, you see here in the purple, this is the first of the Omicron strains. And by the end of 2021, Omicron had completely taken over, and that was all that was circulating, one Omicron variant or another. So tixagevimab and silgavimab were an additional pair of antibodies developed that were, again, showed the ability to prevent hospitalization or need for emergency room visits in symptomatic outpatients and was given emergency use authorization. If we look now at how these different antibodies compared in terms of activity against the various viruses, so here there are the antibodies themselves, either singly or in combination, and these are the different strains. So here's alpha, beta, delta, and then Omicron. So you can see etazivimab and bamlanivimab completely lost activity. Imdevimab was inactive against Omicron, as was casirivimab. Interestingly, tixagevimab had significantly reduced activity, but silgivimab retained some activity. So in combination, so if you look here in this line, the two CoV-2 antibodies, there was still pretty good activity. And this was one of the oddities of the development of these monoclonals. Once they were put together, you couldn't take them apart. And so the FDA gave emergency use authorization for the combination, even though they knew well that one of the antibodies had no activity whatsoever, and there was little evidence that the combination was any better than the individual antibody which retained activity. But because of the regulatory process, it just couldn't be teased apart again. That was already true with bamlanivimab and etazivimab, where it was all etazivimab that had activity by the time the drug became approved, but they never took the bamlanivimab out. But you can see here that sotrovimab has reduced activity. Of course, the original antibodies had lost activity, and whereas just by comparison, at the very bottom, the small molecule inhibitors retained complete activity. There was no emergence of resistance, and there still hasn't been an emergence of resistance to either nirmatrelvir, to molnupiravir, or to remdesivir. Although sotrovimab retained some activity against the initial Omicron variant, BA1, it lost activity against BA2, if I can get my pointer back here, there we go. So here in blue is BA1, and you can see there's still reasonable activity, but the red is showing BA2, and this led to a restriction in the use of sotrovimab to those regions where BA2 and its progeny were not yet circulating. And unfortunately for sotrovimab, although BA1 was the original Omicron variant to emerge, all subsequent Omicron progeny really descended from the BA2 variant, and that includes the variants that are circulating today. So sotrovimab had a clinical half-life of about 6 months or so before it no longer remained useful. Now, there then emerged bebtelovimab, which was studied in one of the NIH-funded network trials, BLAZE-4, and now we also begin to see a shift in how these antibodies are being authorized for use. Up until now, what I've shown you are randomized phase 3 trials where clinical efficacy is the primary endpoint, the ability to prevent or reduce the risk of disease progression. That no longer became feasible, both because of the changing epidemiology of the pandemic, because of the increasing rate of vaccination and prior exposure to SARS-CoV-2 that led to increasing pre-existing immunity of various degrees in the population. And so instead, bebtelovimab was authorized for use on the basis of this phase 2 study, showing that it significantly accelerated the clearance of virus compared to placebo. And you can see here the black line is the rate of decline in the placebo, the red line is bebtelovimab alone, and then the blue line is this triple combination of bamlanivimab, etazivimab, and bebtelovimab. And there's no difference because these two other antibodies are essentially inactive at this point. But this is not a whopping difference in clearance rate, right? We're talking about a couple of days and about a log difference in virus load, yet that served for emergency use authorization. bebtelovimab retained activity against all of these initial Omicron variants all the way up through BA.5, whereas these others had lost activity, although the combination of tixagevimab and silgevimab had activity against some of the BA.2 against the BA.2 progeny, even though its activity against BA.1 was less impressive. But the virus continued to move on, and whereas we almost ran out of letters because there were the BA series, and then there were several others. Now the BQ series, and eventually the XBB series, which by 2023 were the predominant variants in circulation. And what you can see is that when XBB and BQ1 became the predominant variants, that now, just looking here at this panel, bebtelovimab no longer had activity against these viruses either. So we've gone through now something, I wasn't really keeping count, but it must be 8 or so antibodies that had sequentially been developed, come into use, and became useless because the virus had moved on. So where are we currently? So the most recent antibody to come into clinical use and to gain emergency use authorization, but only for prevention and only in immunocompromised people, is pemivibart, which has activity against Omicron variants, including the most recent variants. And these are, I've shown only a selected set. There's a much more extensive list of these variants in the fact sheet that accompanies the pemivibart prescribing information. But LP1 and XEC are among the most recently circulating viruses, and pemivibart in an update from March, for which there isn't there aren't any actual data, but just a statement from the company, still shows activity against LP1.8. And you can see that what's circulating currently, according to the CDC, the XEC variant has gradually been replaced by the LPB.1, and so LPB.8 is a minority variant that is beginning to emerge, and there's still activity against that. So where does that leave us, and what are the lessons that we can learn? So these antibodies were highly effective. But the viruses are forever. They keep changing. They keep adapting to the population. So these mAbs come and go. We've been very fortunate with RSV that the monoclonal antibody is highly effective in prevention. Whether that will remain the case, or whether we'll eventually see a drift in RSV to other variants that escape from the current monoclonals, we'll have to see. Because clearly the evolution of SARS-CoV-2 outpaced the development of new monoclonals. And as a result of many factors, not least of which is the continued evolution of the virus, but also the increasing challenge of demonstrating efficacy, the development of new monoclonals for SARS-CoV-2 has now slowed to a trickle. Invivyd remains committed, according to their representatives, to developing new antibodies should pemivibart lose activity, but we'll really have to see if that occurs. And then the changing landscape for conducting clinical trials in COVID-19 overall has become much more challenging because of the high prevalence of population immunity, the very low rates of hospitalization and death outside of selected populations, and because there's no longer a national emergency, it's less clear how an emergency use authorization can be issued, because it requires the declaration of a health emergency in the first place, not to mention the fact that it's not clear that there's anybody home any longer in any of the regulatory agencies able to make these decisions in an informed manner. So let me stop there. I will thank you for your attention, and I think I'll take questions now if I can, because I'm going to have to run out. So great. So thank you.